Hi guys, this is Kristen Martinez. I'm an expert in trauma-informed care, and today I am going to be taking some research and putting it into application and how some of you guys in community agencies can start to make it work for you. So what I'm going to talk about, I have it right here. I actually have to read the title because I can't remember it. It's kind of long. You know, sometimes research articles are crazy long. So it's called Trauma-Informed or Trauma-Denied: Principles and Implementation of Trauma-Informed Services for Women, which is definitely something I'm really passionate about because women tend to get less, I'm not gonna say less quality care, but care that isn't always sufficient for the needs that they have. And this article, I love it because it outlines 10 different things that we should be looking for in trauma-informed care, especially when we're working with women. So the authors, Principles and Implementation of Trauma-Informed Services for Women by Denise Elliott, Paul Bjelajac, I'm gonna murder his name, Paul Bjelajac, Roger Fallot, Lori Markoff, and Beth Reed. And I'm really excited to share this again. So I just want to read, you have to be a member. I'm sharing it also because a lot of you guys don't always have access to like research articles. And I think it's really important to put a lot of this research into plain speak for you guys so that we can start to understand it a little bit better. So the 10 principles that they talk about being really important for trauma-informed care in regards to women is recognizing the impact of violence and victimization on development and on our coping strategies. So this is also and this article is really talking about taking into consideration the historical experiences of women and our historical experiences of being victimized and being victims of violence without having a voice. So what in this article is talking about for the step one or principle one is that we need to recognize that that's a historical and current experience of women, and we need to really bring that into our treatment programs. Number two, we need to have services that identify recovery from a primarily trauma-based goal. So what they're talking about here is that when we're working in services, and especially when we're working with women who have been victimized or where there's substance abuse involved, is that we need to shift our focus from like treating substance abuse or getting them from out of codependent relationships. And we need to shift our focus completely onto focusing on healing the trauma. And what this is showing is a huge review of research that shows that when we focus on the trauma, when we shift our lens to the root of the issue, that all of these subsequent issues will start to change, right? So codependent relationships stop, boundaries increase, substance abuse decreases. Is because we're no longer treating the symptoms of the problem, we're actually getting to the root of the problem. So the third principle is actually pretty lengthy, okay? So trauma-informed services employ an empowerment model. And when they're talking about that, they also have 7 items within that, which I'm gonna read because I think that it's important to read. So the model of using an empowerment model, there's a partnership between women seeking services and the helper, in which both are valued for the knowledge base they bring to the problem. Okay, so this is heavy. So I think this is heavy because a lot of therapists struggle in seeing their own value and their own knowledge that they're bringing to the therapy room. And then the part 2 is that we can't only see ourselves as an expert, although this is saying we need to both see ourselves as an expert and we also need to see our client as an expert and empower them to the same level we're at. It doesn't mean that we lower ourselves and say we're not an expert and we don't know what we're talking about and the client knows everything. It's actually very separate. It's lifting ourselves up and saying, look, I know this is the research, I'm gonna help you. And at the same time, you also know the best way to use me. And so you need to tell me, and we need to share this experience and work together towards empowerment, towards healing, towards healing trauma. Okay, I know this is going to take a while. So number 2, the goals of the work are mutual and established collaboratively. So gone are the days of me writing a behaviorally based goal or a goal that I think can be used. It's all about why are you here and what do you want to accomplish? Okay. And also, I'm also saying, like, I'm not sure if that is the best goal for treatment. And I'm wondering if we can work together to build a goal that might be more attainable or more focused on trauma-related issues. Number 3, a woman's issues are understood as created or influenced by the socio-political context, and the impact of her cultural context is considered. Again, this is looking at the world we live in, the historical world, and it's also taking into consideration that every woman does not have the same experience. Obviously, some groups of women are far more marginalized and belong to cultures and groups that are oppressed in our society. And we need to recognize that. We need to bring that in the room, not only our feminine qualities, like that there's a woman in the room, but also what other groups do these women belong to? You know, do they identify as Black, or do they identify as African American or a person of color? Do they identify as Muslim? Do they identify as LGBTQ? All of those things need to be addressed. And if you stay tuned next week, I'm going to have a great freebie where I have a worksheet that you can actually bring into a session with you to look at what kind of groups you belong to and what kinds of groups your clients belong to. So stay tuned, and it's part of this trauma-informed care. Okay, number 4. The program facilitates the formation of a forum where women can relate to each other in a mutually supportive way. And I think this really comes down to any groups that experience oppression, and obviously women are one of those groups. They need to have a space where it's just theirs, where they can express and support each other in their experience of oppression, of what's going on in the world, what's going on in the space, and how it relates to their own personal experience. And that is one of the most empowering things. I don't know about you guys. I'm a woman, so I understand the power of sitting down, having mimosas with a group of girls. Obviously, in a substance abuse treatment program, we're not going to do that, but that idea of just going out for coffee with the ladies and sharing that shared experience of what it's like to be a woman and the different issues that affect us. Okay, the woman feels her experience and choices are validated, not dismissed. This is really important. Sometimes, a lot of times, people in oppressed groups are kind of like food, and we really need to make sure that we're validating when women are making a decision for themselves. The work builds on her existing strengths so that her sense of inner strength is increased. Number 5, the woman feels her experience and choice. We already did that one, sorry. So number 6, the experience of collaboration provides both the woman and the helper with increased knowledge of self and others, increased self-worth, and increased competence and comfort in taking action on personal goals. I think that's self-explanatory. It's for self-explanatory, right, guys? Okay, so number 7, the ultimate goal of the empowerment model is to expand a woman's resources and support network, such that the woman becomes less and less reliant on professional services. I know for a lot of you in community agencies, this model, and the more I get into this article, the more you'll think that this is very in line with the idea behind intensive services, where we kind of come in and surround somebody with professional services like therapy, like rehab, with parenting support, and we come in and we go like this, right? But the purpose is to start building with the person up, to grab onto the natural supports around them, so that over time professional support can decrease and eventually exit. And this article is pretty much saying that's right on track. So if we could successfully implement those programs, then the outcomes should be awesome. And obviously, for those of us in community mental health and who have a lot of experience in that, it's a very complicated idea to really fulfill those programs in the way that they were meant to be for a number of reasons, which we're not going to get into today. So let me go on. So that was for principle number 3. Principle number 4, trauma-informed services strive to maximize a woman's choices and control over her recovery. again, a lot of times women struggle with extremely interpersonal trauma, and then the historical trauma that comes on top of that really leave us feeling like we don't have control, that we're victims of our situation. And so the more that we can place on the ability of a woman to make choices and to have control, the better she's going to feel about herself. The more we take control and the more we're in control and we feel in control, the better our lives turn out. Number 5, trauma-informed services are based in a relational collaboration. I think every therapist knows that the strength of therapeutic outcomes is so related to that strength of the therapeutic relationship, of the rapport that you have with your clients. And sometimes we often drive ourselves into intervention before we have established a sufficient relationship to make these changes possible. And so if you're ever feeling like this intervention ain't flying, right? Like it's not taking to the client and you can't figure out why, I suggest you always go back to your rapport building, using humor, using yourself. Again, like think about building a relationship in your personal life. It's a little bit different with clients, but at the same time, like you have to bring something into the room to get something from your client, especially with a trauma survivor. It requires even more of yourself to be in the room, or else they won't trust you. I mean, I wouldn't trust somebody. I'm a trauma survivor myself, and the first therapist that I started to really trust is one that disclosed that she was a survivor of sexual assault as well. And so I was like, she's going to understand me. She's going to get me. And so sometimes it takes a trauma survivor to help a trauma survivor. And later on in this article, it talks about the idea of how in NA or AA, there's this idea that an alcoholic can help an alcoholic because they've been through it. This model really suggests that in trauma-informed care, to bring in your own self, your own trauma, because it takes a survivor to heal a survivor. Okay, we got relational collaboration. Okay, number 6, trauma-informed services create an atmosphere that is respectful of survivors' need for safety, respect, and acceptance. I mean, this article is so good. That's why I picked it. It's just like, yes, 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 yes. And not only is this article amazing, it's also, if you are a trauma buff like me, you know that this is totally in line with polyvagal theory, with everything, with body-based psychotherapies. This article is just speaking the truth of what we know is good trauma-informed care. And one day I will totally get into polyvagal theory and it'll be amazing and you'll love it. And I'll totally take the crazy language and simplify it, because polyvagal theory I think it changed my life, and it changed my life as a therapist. Okay, next. Principle 7, trauma-informed services emphasize women's strengths, highlighting adaptations over symptoms. Just saying. And resilience over pathology. I think a lot of us already know the importance of shifting symptom reduction, because that's a medical model. Symptom reduction is a medical model. It's not a mental health model. And what this article is saying is like, stop the medical model because it doesn't work. Stop. What we need to do is stop looking at things under symptoms and pathology and diagnosis. And by the way, probably everybody can meet PTSD diagnosis. I am passionate about post-traumatic stress disorder, but I also think that a lot of the other disorders pretty much are just trauma expressing itself in different layers. But that's me. But so what this is really talking about is shifting from the medical model into that trauma. What's the root? And how do we get into the root? Not only that, we're also talking about stressing the grittiness and the resilience that comes from trauma. Okay, because that's true. And I talk about that all the time to a lot of great leaders. The reason they're great leaders, and it comes to mind is Oprah, is because they have had a significant amount of trauma. And through that trauma and living through it, they built grit and resilience. right? So we need to focus on that rather than focusing on how damaged somebody is. Okay. The goal, sorry, number 8, the goal of trauma-informed services is to minimize the possibilities of re-traumatization. Absolutely. Absolutely. This is very complex, and I'm thinking it deserves its own, video, because the idea of re-traumatization is very complex, in my opinion. It's beyond triggers, and understanding re-traumatization and how it can happen and how the body's involved in that, it's going to take me like another half an hour just to explain that, right? So just keep that in mind for the future. We want to be minimizing re-traumatization. We don't want to be, okay. For example, one of the biggest, and a lot of you in community mental health agencies are going to hear a lot about desensitization, which is something that's really common and a really common evidence-based practice called TFCBT. And the idea is not just, we think it's narrative. It's actually not true narrative therapy because of the recounting of the actual trauma narrative. And part of the reasons for the recounting is not to shift the narrative. Its true intention is desensitization. And what we're actually doing, and we know this from a lot of the research, especially polyvagal theory, is that every time we initiate a traumatization, okay, I love this example. For example, you got a cat who grabs a mouse, right? This mouse, and he's there, he hasn't had any trauma yet. Then the cat starts batting him, and the rat plays dead. So the cat stops, because the cat doesn't want to play with a dead thing. Okay, but the cat's smart and it knows that it's just playing dead. So this time the rat gets up again, and boom, 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 the cat starts batting it again. Okay, the rat this time goes dead for a little bit longer, hoping the cat gives up. Cat doesn't give up. Whap, 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 does it again. And this cycle repeats itself over and over and over again until the rat dies. And so when we're thinking about desensitization, this is this idea that we're actually traumatizing somebody over and over and over again until the nervous system shuts down. And so, yes, when you recount it again, the person's desensitized to it, but it's not actually meaning that they've healed from the trauma. What it actually is happening, and we see it with complex trauma a lot, is that the more the trauma happens, the more you get re-traumatized, is that you're actually, the way that your body is responding to the trauma changes. So like somebody who repeatedly experiences trauma, their blood pressure does not spike up. Their heart rate does not always increase under stress of trauma or being triggered. What actually happens is the opposite. It shuts down. So their blood pressure drops. Their heart rate slows, right? It's because all of the blood is rushing to the core to protect it. And so it's fascinating, and it's terrible that even with this research and all of this coming out, that we're still using to treat trauma forms of desensitization. I mean, that's my soapbox, and that's also my personal thing after reviewing a lot of research and a lot of ideas, is like how effective really is desensitization in treating trauma. It's effective for other things like phobias, but when we're talking about trauma, something about like recounting the details of a rape over and over and over again, I don't know, from just a common sense model, doesn't seem very effective. Next. Number 9, trauma-informed services strive to be culturally competent and to understand each woman in the context of her life experiences and cultural background, which they talked about previously. Very important, right? Very, very important. All right, guys. Number 10, trauma-informed agencies solicit consumer input and involve consumers in designing and evaluating services. What this is talking about is when we're working in programs and we're working in agencies, a lot of times we have these assigned protocols to use, and they kind of like, use TFCBT to treat this, or use narrative therapy to treat this. And what this is suggesting is that what we need to be doing is involving our clients. Consumers, by the way, in community health speak is clients. So clients, what we need to be doing is involving clients and how they think they will be best served. Now, when you're in private practice, it's a lot easier to go with that flow, to build the rapport enough to understand what your clients are asking from you and for you to ebb and flow with them. And we need to take that rapport building phase that happens in private practice and apply it to our community-based services, so that while we're developing our treatment plans, and the way we're going to do this is that we're actually integrating exactly what the client wants and the client needs, so that we can give it to them, because we're the expert and we can give them what they need. Absolutely. But we need to ask them what they need, and we have to understand what they need. We can't tell them what they need. And looking at it from even a larger perspective is not just designing individual treatment plans in that form, but asking the clients, like, to design the entire treatment program. Pretty much, like, what do you need? Do we need a women's group? Do we need this? Do we need that? Like, how do you think we're doing? We need the clients who are struggling with this problems to be telling us, and we need to understand, is it effective? Is it helping you? Is it hurting you? Right? Like, what needs to change? What do you need? We need to give them the voice, and we need to understand. We can't just throw research things at them and be like, this works, this works, this works. How do we know it works? We need to ask them if it's working, and we also need to ask them if it's working. So if we know, are we applying the strategies correctly? All right. So I really enjoyed this article, and I hope you guys enjoy it too. Every Friday, I'm going to be going over a research article. And by the way, in the link, I'll cite the research article for you guys in case you want to look it up. And so every Friday, I'm going to be taking a research article, and I'm going to be going through it, reviewing it, putting into speak like what it means, and trying to help you guys start integrating this very important research into your everyday use, and also to help you feel more empowered as an expert in treating trauma and being trauma informed. So this was Kristen Martinez. I'm, again, an expert in trauma informed care, and I help community therapists feel supported in their agencies doing trauma informed work. Thanks, guys. Good luck.